So let us start the ninth class. In this we are going to continue the drug metabolism. In earlier class we have discussed the drug metabolism, particularly the phase 1 drug metabolism. So in this class we are going to discuss drug metabolism, drug excretion, half-life of the drug, and some very important terminology like first pass metabolism, then total body clearance, then ion trapping. We are also going to discuss enterohepatic circulation, also going to discuss steady state concentration of the drugs. So let us start the phase 2 drug metabolism. So as we earlier discussed, the phase 1 and phase 2 are the way of drug metabolism in which we already discussed the phase 1. So now we have to start with the phase 2 drug metabolism. Under the phase 2 drug metabolism, this is known as conjugation reaction. This is also known as synthetic reaction. This is also known as anabolic reaction. So these are the, you can say, some of the synonym for phase 2 drug metabolism. So as we know, the main purpose of the drug metabolism is to convert a drug into ionic compound or water soluble compound, and that has to be excreted out through the excretory route very easily. If the drug are not going to be metabolized, the drug are going to slowly excrete from the body. So body actually don't want to keep any foreign body, any xenobiotic. So for that, the body is going to go through the metabolism to convert it into ionic compound or water soluble compound. So it should be easily excrete out from the body. The main enzyme of the phase 1 drug metabolism is residing in the endoplasmic reticulum of the cell, and the enzyme is called cytochrome P4 system enzyme, also called microsomal enzyme, also called mixed function oxidase, that is MFO. So phase 1 enzyme is microsomal enzyme residing in the endoplasmic reticulum. However, the phase 2 drug metabolism is residing in the cytosol or cytoplasm. So this is very important differential point between the phase 1 and phase 2. Not only that, the majority of phase 2 metabolism enzymes are present in cytosol. However, the enzyme of glucuronide reaction, that is also called glucuronidation, is, you can say, exceptional, or you can say the variation. So this enzyme under the glucuronidation reaction of phase 2 metabolism is not present in the cytosol, rather it present where the phase 1 metabolizing enzyme is residing, that is in the endoplasmic reticulum. So this is very important. Usually the drug or the metabolite of phase 1 reaction proceeded towards the phase 2 reaction, and the main purpose of the metabolism is to not only convert in ionic form or water soluble form, but it also inactivate the drug. So inactivation of the drug is also occurring through the metabolism of the drug. So this is very important. So you can say the majority of metabolism are the inactivation of the drug, but some in which the drug may get activated, not inactivated, activated. So those drug may be called prodrug, and some of the example other than prodrug like morphine. Morphine, when you are going to administer as such, then within the body that get converted into metabolite with phase 2 metabolizing enzyme, and the metabolite is morphine 6 glucuronide, that is the phase 2 metabolites. So this morphine 6 glucuronide is a metabolite of morphine, and this is not rather inactive, rather active, and its activity is about 2 times than the parent compound morphine. So this is very very important. So you can't say all reaction of the phase 2 or phase 1 is inactivation, but it also include activation of the drug like prodrug, and like the example like morphine. So this become very very interesting. So what is the name of the phase 2? Is the conjugation reaction, is the synthetic reaction. So what will happening in this reaction of the phase 2? The drug that goes through the phase 1 reaction, after phase 1 reaction, it is going to form the metabolites of the phase 1. And that metabolites, when it is going through the phase 2 reaction, so the drug of the phase 1 reaction is going to conjugate with the endogenous substance, or you can say the substrate, endogenous substance or substrate that combined with the drug metabolites or with the drug or the drug of the phase 1 reaction, and after the combining with the with the endogenous substance, or you can say the substrate, they form a compound that called the phase 2 metabolites or phase 2 compound, and that is ionic, may be ionic and may be water soluble, and it has to be excrete out from the body. So this is the principle of the phase 2 reaction. In phase 2 reaction, other important thing is that mainly the phase 2 reaction require very very important thing, the endogenous substance, that is also called substrate, and for combining of this substrate with the drug metabolites of phase 1 reaction or with the drug, it required the enzyme, that is the phase 2 enzyme, and the name of the enzyme is called transferases. So all enzymes under the phase 2 reaction are called transferases, phase 2 transferases enzyme, and these all enzyme is helping to attach the substrate or endogenous substance with the phase 1 drug metabolites to form or to synthesize a compound of the phase 1 phase 2 metabolism. So where, as we already discussed, the what are the things that required. So we already discussed this is occurring in the cytosol. So enzyme of the phase 2 reaction is present in the cytosol. So this is interesting. Whereas the substrate, that is the endogenous substance, and the enzyme of the phase 2 reaction are enzyme of the phase 2 reaction are called transferase enzyme, and the substrate or endogenous substance that is going to attach with the drugs are like PAPS, that another one is UDP glucuronic acid, then GSH, then acetyl coenzyme A, then SAM. So these all the fives are called endogenous substance or also called substrate. And if you go through the name, you will find the name of the substrate itself have the component that is going to give the indication what is going to attach with the drug. So these are the things the mention here. So these acetyl, here is the methyl, here is the glutathione, here is the glucuronic acid, here is the sulfate. So these endogenous substances or substrate are going to attach with the drug with the help of enzyme that called the transferase enzyme. And accordingly, the name of enzyme is also there. And what is going to be at addition with the drug, that is the mentioned here. So if the substrate is PAPS, that is the phosphoadenosine phosphosulfate, the name of the substrate, and this is going to give the addition of sulfate with the drug, and that is going to form the phase 2 phase 2 phase 2 metabolites. So that we are going to discuss here one by one. So if the substrate is PAPS, that is going to give the sulfate, and that sulfate is going to attach with the drug of the phase 1 reaction to form the phase 2 complex compound or the phase 2 metabolites. So under the influence of enzyme transferase, so because this is giving the sulfate, we are calling the name of enzyme sulfotransferase. Another one is the glucuronic acid. So what is the name of the substrate is UDP glucuronic acid, that is uridine diphosphate glucuronic acid. And the name of enzyme is also the matching with the substrate. So name of the enzyme is glucuronosyl transferase, indicating the glucuronic acid, and the substrate is glucuronic acid. So this glucuronic acid is going to attach with the phase 1 drug or the phase 1 drug metabolites, and therefore form the phase 2 compound of the drug, and that occur again with the help of enzyme that we are calling it transferase enzyme, and the name of the enzyme is UGT, that is U for UDP, G for glucuronosyl, and T for transferase, and U for UDP. So this is the name of the enzyme. And what is going to attach with the drug? The glucuronic acid. So the first number, third number, fourth number, and fifth number, their enzyme are present in the cytosol. However, the enzyme of the second one, means UGT enzyme, is present in the endoplasmic reticulum. So the enzyme is microsomal enzyme. So this is very, very important and interesting, and it differ from the other enzyme of phase 2 reaction. Now the third is the attachment of glutathione. So which one endogenous substance or substrate is going to give this glutathione? So glutathione itself, reduced glutathione, is going to give the glutathione, and this reaction with the drug occur with the help of the enzyme. We are calling it the GST. G stands for glutathione, S stands for S, and T stands for transferase. So all the enzyme are transferase. So this is going to give the glutathione, and the compound that form after reacting with the drug is glutathione conjugate, and all the reaction have its name. If this resultant component form, the name of the reaction is sulfation. Name of the reaction under this is glucuronidation. Name of this acetyl is acetylation. The name of this one is the reaction is the methylation. So name is also according to the attachment of the substrate. So this is very, very interesting. The third one is the glutathione. So glutathione get attached. Next is the acetyl coenzyme A. This is going to give the acetyl. So the reaction is acetylation. This is going to give the acetyl group, and this will again occur with the help of enzyme transferase, and name of the enzyme is N-acetyl transferase. So this is very, and the last one endogenous component is S adenosyl methionine. This is going to give the methylation of the drug, and therefore the name of the enzyme again is transferase. So because this is transferring the methyl group, so name of enzyme is the methyl transferase. And these methyl transferase, when you are going to see in the human being, are COMT, POMT, TPMT. So these all are the methyl transferase enzyme. So this is all about the phase 2 reaction. This is very, very important and interesting also. Here I'm going to mention one most important thing is that when you have to go through the general principle of the metabolism, you will find drug primarily metabolized or extensively metabolized or mainly metabolized, or metabolism is started through in a sequence, that is through the phase 1 reaction, and after phase 1 reaction this is going to form the drug metabolites, and this drug metabolites is again, if drug metabolite is or a drug as such is not ionic, not water soluble, then again it will go through the phase 2 reaction. So and thereafter the phase 2, after the phase 2 reaction of the conjugation reaction, now the drug metabolites is ionic in nature and water soluble, and it is going to be excreted out through the urine, that is the kidney. So this is occurring in the sequence, means ki first it goes through the phase 1 and thereafter it goes through the phase 2 reaction. But there are exceptions. And what these exceptions? Or you can say this is not follow the general rule. Like one drug, isoniazid. Isoniazid is actually an anti-tuberculosis drug, and this isoniazid is first go through the phase 2 reaction, and after the phase 2 reaction that is occurring first, it forms the acetylation of isoniazid. So acetylated isoniazid then again goes through the get hydrolyzed by phase 1 reaction and form isonicotinic acid. So if this is the just against the general route, means ki first drug will not always go through the phase 1 and then phase 2. Then some of the drug may start with the phase 2 and it may proceed towards the phase 1. The example is isoniazid. Here I am going to mention one very, very interesting thing that I have left in the phase 2 reaction. The glucuronosyl transferase enzyme, that is UGT, is lacking in the neonate. So this become very, very important. So if a neonate lack this UGT enzyme, glucuronosyl, some of the species, animal species, are also lacking this enzyme. So if a drug that will go through this phase of the metabolism, and if the patient is having deficient of this enzyme, the drug will will not pass through the glucuronidation reaction. So if the glucuronidation reaction gets slowed or not occurring, then the drug will not get metabolized and will not excreted out through the urine, or it may slowly excrete out through the urine. So what will happen if the drug will slowly excreted out from the body of the human being or an animal? It will remain in the systemic circulation. So when it remain in the systemic circulation, this is going to produce the toxicity. So the example of an antibiotic is the chloramphenicol. So this chloramphenicol antibiotic is metabolized by phase 2 reaction, glucuronidation, and this glucuronidation reaction enzyme is lacking in the neonates. So if lacking, then this chloramphenicol not get metabolized or slowly get metabolized, and therefore get accumulated in the systemic circulation, and therefore this is going to produce the toxicity. So this is going to produce the toxicity in neonates because this is lacking this enzyme in the neonates. So this is all about the phase 2 reaction. Now we have to go through the one more terminology that we are calling it the first pass effect, and this is also called pre means before, systemic means systemic circulation, and metabolism is the metabolism. So when usually you are administering the drug by oral route, it will reach in the systemic circulation, and thereafter systemic circulation it will go through the liver, and therefore this is going to produce the metabolites of the drug. Because as we earlier discussed, the places of this enzyme, presence of this enzyme, so major presence is in the liver. The cytochrome P450 enzyme is mainly present in the liver for metabolism. So when you are administering the drug through oral route, it may leave this protocol, and it will reach to the liver through portal system. Through portal circulation, it will reach to the liver, and thereafter it will go to the systemic circulation. So what will happen when you are administering the drug like aspirin, that is non-steroidal anti-inflammatory drug, like then if you are administering antihypertensive drug like glyceryl trinitrate, isosorbide trinitrate, this is used in the angina. Then if you use the drug like levodopa, that is used in the Parkinson disease. Then if you are using the local anesthetic like lidocaine, if you are going to use the beta adrenergic blocker, that is metoprolol or propranolol, these two are used for the therapy of the hypertension. And the drug like the bronchodilator salbutamol and the calcium channel blocker verapamil, that are used for the therapy of blood pressure. So when you are using these drug majority of the part, some part of the drug get metabolized, passing through portal circulation from GI tract, it get absorbed. So some of the part of the drug get metabolized in the GI tract while absorption, and also before reaching to the systemic circulation, it reach to the liver and get metabolized here. So once it reach in the systemic circulation, their bioavailability is lesser than the drug get absorbed. So this less amount is because of the metabolism of the drug in the liver as well as the GI tract by the enzyme, is called first pass metabolism or pre-systemic metabolism. That is, the metabolism of the drug occur after the absorption in the GI tract and in the liver before reaching to the systemic circulation, and their availability is lesser than after absorption, is called first pass effect. So this is very, very important and interesting. Now we have to go through the second part of this lecture. So now we are going to go through the drug elimination, that is also called the drug excretion. So what is drug elimination or drug excretion? When you are administering the drug, and after its metabolism of the phase 1 and phase 2, it has to be excrete out through the urine. There are mainly the major organ of excretion is the kidney. So major organ of the excretion is kidney. So renal excretion occur. So first under the excretion of the drug. So what is excretion? Excretion is a process by which drug is going to be excrete out from the internal environment to the external environment through renal or renal route, by renal and non-renal route, and which is irreversible, is called drug elimination or drug excretion. So what is drug elimination or excretion? It is simply a process of transport or excretion of the drug, and the process is irreversible to carry out to transport a drug from internal environment, that is the body, to the outside environment, that is the outside, is called excretion through the renal, that is the kidney, or non-renal route, that is the other than renal, is called the excretion or elimination of the drug. So how this will excretion will occur? If you are considering the renal, so the kidney, another is the non-renal route, that is the not the kidney. So non-renal route and renal route we are going to discuss in the detail. So see here, when you are administering the drug, when it get metabolized by one and two phases reaction, it will comes in the glomerulus. So when it comes in the glomerulus, so in the glomerulus, what will happen? Drug that are, if the drug is unbound form, if the drug is in unbound form, it will filtrate in the Bowman capsule, and this is called the glomerular filtration, and the process is called glomerular filtration, and the filtrate is called glomerular filtrate, and the process, so through the kidney by three ways, by three process, drug has to be eliminated or excreted out through the kidney, and these process are: first, glomerular filtration. So through glomerular filtration, about 20% of the drug are going to be excreted out through the urine, and uh, above that, I mean about 80% of the drug is excreted out by another two process that we are going to discuss. In these two, the second one is the majority of drug should be excreted out. So under the glomerular filtration, drug has to pass through the glomerular, and it will get filtered in the lumen, in the lumen, tubular lumen. So in the lumen the drug will come. So that drug, when you it will pass through the glomerular, must be or primarily unbound form. So this is very very important. So only unbound form of the drug is coming in the lumen through the glomerulus as a glomerular filtrate by glomerular filtration process, and about 20% of the drug is going to come in the lumen, tubular lumen, or particularly you can say, you will see in the Bowman capsule, and it will excrete out through the urine, because urine formation is occurring here in the lumen, and that will carry out the drug. Second process that mainly occur in the proximal tubule, and where occur? In the tubule. So proximal tubule. And this process, what will happen? This is taking the active one because it is energy dependent, and also take the help of the energy. So this is active process, and also carrier mediated. So this carrier mediated that is carrier mediated, that we are also calling it the transport. So in second way of the process of excretion of the drug is the is called active tubular secretion. Second is called active tubular secretion of the drug. This is also called active carrier mediated transport of the drug in the lumen, tubular lumen. So this is active one, first one, because it is an energy dependent. Second one, because it required a carrier, that is called transport. So it required transport. So what will happen? This transporter or this carrier to which the drug get attached, and this transport is going to attach with the drug, and that it then it will come in the lumen, and when it comes in the lumen, it is going to be excreted out. So because this is the energy dependent, that means the concentration of the drug in this perivascular space, this is surrounding of the lumen, the concentration of the drug is lower. So it will move from lower to higher concentration. This means against the concentration gradient. Drug is moving out against the concentration gradient. So moving this drug from higher to lower to higher concentration, that is the against the concentration gradient, it requires the energy as well as the carrier transporter. So with the help of that, drug is going to come in the proximal tubule, and thereafter it will excrete out through the this one. So here what are the, and which is about the 80% of the drug. Here another interesting point is that usually the drug that is coming through this active tubular secretion are bound for. The first that we have discussed, that is with the unbound form, but here the drug is bound with the protein, plasma protein, and therefore it will come through this way. And the last one is the occurring in the mainly distal tubule, and also majority in the distal tubule. So in distal tubule, rather the drug is not coming in the rather drug is not coming in the lumen from the tubule, from the perivascular space, rather occurring just opposite. What it means, the drug that reach in the lumen of the Bowman capsule of the kidney, the concentration of drug in the distal tubule of collecting that is getting rises, and rises. So when the concentration of the drug get raised in the lumen of the Bowman capsule of the distal tubule, and their concentration is higher than the perivascular space, so drug is going to be reabsorbed. Rather it is coming in the lumen, it get reabsorbed. So the condition for reabsorption is what? The condition, the drug should be lipophilic. So drug only that are lipophilic, that are unionized, that came in the distal tubule of the kidney, lumen of the distal tubule of the kidney, get reabsorbed. So this is called passive reabsorption, passive tubular reabsorption. So why the name is passive? Because it is energy independent, and it is occurring in the same path of concentration gradient. Means the drug is moving from higher concentration to lower concentration, and therefore it get reabsorbed. So only the lipid soluble or unionized drug. So after that the drug, so what will happen, again drug reach in the systemic circulation, and it will helps to maintain the concentration of the drug for longer time interval in the systemic circulation. So therefore the doses should be managed accordingly. So this is very very important. So first one is the glomerular filtration process, second one is the active tubular secretion, and third one is the passive reabsorption. So these are the way of the excretion of the drug. So this is important. Now we have to discuss some more point about this. So this is the definition, this we already discussed. So here what is important, so renal excretion, renal elimination of drug occurring by three processes that we already discussed, that is the glomerular filtration, that is the second one is the passive tubular reabsorption, and third active tubular secretion, and third one is the passive tubular reabsorption. So the glomerular filtration is about 20% of the drug is going to be excreted out through this one, and that one is usually unbound form. This is very very important. What are the other point is that glomerular filtration of the drug is dependent on the GFR, glomerular filtration rate, and this is going to influence very importantly. Also this is depend on the renal blood flow. Also it is depend on the protein binding of the drug. And take the example of the, under this is the drug fluoroquinolones and gentamicin. These two drugs are going to be excreted out through the this way. I mean the glomerular filtration as a glomerular filtration rate. And what will happen if usually you will find GFR is about 125 ml per minute. Usually in normal case the glomerular filtration rate is about 125 ml per minute. So if the glomerular filtration rate get reduces, the glomerular filtrate containing the antibiotic or the drug get also come less amount. So if it will come less amount in the urine, so less drug is going to be excrete out. So where the drug is there, so drug still remain in the systemic circulation, so it will persist for longer time interval. So accordingly we have to manage the dosage. Take this two example. If the glomerular filtration rate is reduced from 125 ml per minute to 30 ml per minute, then the dosage of these two drugs like fluoroquinolones group antibiotic like ciprofloxacin, norfloxacin, enrofloxacin, getafloxacin, levofloxacin, their dose, and also aminoglycoside antibiotic gentamicin, their dose get reduced to half. So this is very very important because its excretion also get reduced. So the dosage also get half life. If it would influence the half life, so their dosage gets reduced. So this become very very interesting and important. Now we have to go through the other point is that the second one, that is the proximal tubular secretion of the drug. If you go through the proximal, the second one way of process of the drug excretion is the proximal tubular secretion. That is the active process. It required the energy, and also it required the carrier, that is called transporter. So it required energy, and usually weak acid and weak bases are going to be excreted out, and interestingly it is bound with the protein, and that is not with the first one, this is with this one. So it will usually bound with the protein. So drug are in bound form with the plasma protein and require the carrier transporter. So this is why this is called carrier transporter system. The two the drug has to be excreted out. Here one drug is very interesting. You have to mug up it and you have to recall it correctly. One drug we called it the probenecid, and these carrier transporter are non-selective. What it means? It means if you are administering two drugs together, and if these two drugs are going to be carried out by same transporter, by a transporter that is same for that transporter, then there may be chances the A drug may carry out first or B drug may carry out first. This is not the low specificity. So if we are administering two drugs together, at that time the role of carrier transporter become very very important and interesting. Take the example probenecid. Probenecid is actually a inhibitor of a carrier transporter. So what will happen if probenecid, if a transporter is going to carry the drug like antibiotic like belongs to penicillin, antibiotic that belongs to cephalosporin, and antibiotic that and another drug like the belongs to non-steroidal anti-inflammatory drugs that is the aspirin. So usually when you are going to give the drug like probenecid, and simultaneously when you are going to give the antibiotic belongs to penicillin and cephalosporin, what will happen? This probenecid is going to stop or inhibit this transport system that is transporting these two. So when this transporter is going to inhibited by the probenecid, the drug like antibiotic like penicillins and cephalosporin is not coming in the lumen. So if not coming in the lumen, so the rate of excretion of drug is get slowed. So if get slowed, so more concentration, more amount of the drug is in the systemic circulation. So the dose of the drug has to be reduced, because the drug will slowly excreted out, because of you are administering the proben acid, which is slowing down the excretion of the drug by stopping the transport system, and therefore this become very important one. And the third one is the distal tubular reabsorption. So here we already discussed, this is the occurring in the distal tubule, and this is rather absorption of the drug, and this is energy independent, and in the same pattern of the concentration gradient. So this will not require the energy, and drug will rather not coming in the lumen of the lumen, rather it is coming out from the lumen, and only this is for the unionized drug or lipophilic drug. And this become very, here I am going to mention about one drug, diuretic. Actually, diuretic drug are only active or only producing action when it is coming in the lumen. In the lumen, the diuretics are acting. So if the drug like diuretics is going to be transported by the transporter, is fastly, you are going to enhance this fastly transport of the diuretic in the lumen, the drug will work more in case of diuretic. Why? The diuretic have to act when it will reach in the lumen of the tubule or the Bowman capsule. So how you are increasing to come in this? By activating this transport system, tubular transport system. So this become very interesting and important. So we are discussing about the third one. So the third one is the reabsorption occur. So this become very important. Take the example of one drug. So this is also called back diffusion of the drug, that we already discussed. This is coming out the drug from the lumen to the perivascular space, because the in the lumen drug concentration, this is the lumen, in the lumen the drug concentration is how high, and in perivascular space drug concentration is less, and so drug is moving from higher concentration to lower concentration through passive reabsorption. So what is the ion trapping we are going to discuss? Take the example. If you are taking a drug that is called phenobarbital sodium, this is a barbiturate, a sedative. So when the urine is acidic and the drug itself is acidic, so drug will not going to be ionized. So drug will going to be reabsorbed. Okay, it get reabsorbed. Why? The urine is acidic, drug is acidic, non-ionic, lipophilic, get absorbed. But when you are making the urine alkaline by giving the alkalizer like bicarbonate, urine get alkalized, and therefore phenobarbital sodium get ionized, and then it will not reabsorb. Why? Because it get trapped. How it get trapped? Because you are making it ionic, and so because of making it ionic, this get trapped, means this is not rather reabsorbed, rather it get excreted out. So it get trapped in the lumen, and because of the formation of the ion. So this is called ion trapping, and it is also going to be excreted. Similarly, weak bases are also going to be excreted out through the lumen, and when the urine is alkaline, the drug is slowly excreted out. But when you are going to make the urine acidic and the drug is base, by giving ammonium chloride, drug will excrete out fastly. So by these means, we are going to increase the rate of excretion of the drug. Now we have to go through the other route of drug excretion. Other route of drug excretion is also called non-renal route of excretion of drug. So non-renal route of excretion of the drug or other route of the excretion of the drug are interesting, that we are going to discuss. And what these are? These are drug are going to be excreted out through the bile. So the excretion is called biliary excretion. So one interesting example is terminology is enterohepatic circulation or recycling. Enterohepatic recycling. So what it is going to tell? This is coming under the biliary excretion. So what will happen? Drug is coming in the GI tract, through the bile, and this is coming in the GI tract. Okay, so this is in the usually in the conjugate form. So what will happen if the drug is in conjugated form? Once it comes in the GI tract through the biliary excretion, within the GI tract, with the help of GI enzyme, this conjugate get disrupted, and therefore drug get freed. So once the drug get freed in the GI tract, then again it get reabsorbed through the then again get reabsorbed. So this reabsorption of the drug is called enterohepatic recycling or intrahepatic absorption or intrahepatic recycling and intrahepatic circulation of the drug. And this is very interesting to maintain the drug concentration in the systemic circulation for longer time interval. So the other non-renal route is the GI excretion. So drug will excrete out through the feces. If this is excreted out through the sweat, it is called skin or dermal excretion. If it is excreted out through the lungs, this is called pulmonary excretion. And this is very important for those drugs that are in the gaseous form, like gaseous anesthetics. So gaseous anesthetics are excreted out through the pulmonary excretion. If this is excreted out through the milk, this is called mammary excretion, and this become important for toxicity for the neonate, or because through the milk it is coming in the neonate, and then in the drug when it is coming in the neonate, this is going to may produce the toxicity. So this become important. So tear is the also route of excretion, genital excretion, then the salivary excretion. So these all are non-renal route of excretion of drug, and this is very important. Now we have to go through that we have to see the non-renal route of excretion, that we are going to see some more point under this. So gaseous anesthetic, that is pulmonary excretion. The example is desflurane. Desflurane is excreted out through the pulmonary excretion. So now we have to go through the other terminology. So here is the quantitative way of expression of the half-life or volume of research. So the half-life of the drug is, you are going to express like that half-life of the drug is equal to 0.693 multiply volume of distribution divided by total body clearance, that is CL. What is CL? CLB or CL is total body clearance. So total body clearance is nothing, is the clearance of the drug from the plasma, and it should be removed out through the urine with time is called total body clearance of drug. And for that the formula is for the half life calculation is that, and for calculation of total body clearance is the total body clearance is the elimination rate constant multiply volume of distribution. K is the elimination rate constant and Vd is the volume of distribution. And this is for the first order reaction. This is the for the first order reaction. They usually follow this formula for first order reaction. So this is very first order reaction or first order kinetic. So this is very important. Now we have to go through the last one, the half life of the drug. So this is very important, half life of the drug. So why this half life of the drug is the important? So if you go through the terminology and you have to define it. So what is the half life of the drug? Half life is clear getting giving you the clue to define. What is that? The term half. Half means adha. Life means adha life. So what we are talking about? We are talking about the drug. So we are talking about the half life of the drug. So you have to define the half life is that, and because this is the life, so this is in respect to time. So here the time is coming, here the drug is coming, and here the body is coming. Here the body is coming, and you have to cumulate it and divide it. So what is half life? Half life is the time which is required by the body to eliminate, to excrete out the half of the drug from the body is called half life of the drug. So this usually follow the first order kinetic. So this is very important, half life of the drug. When you are administering the drug repeatedly in a patient, then a time will reach, the drug concentration reach at a state we are calling it the steady state concentration. The concentration is the called steady state concentration. So what is a steady state concentration? Is the state of the drug in which the rate of elimination and rate of administration is quite equal, become equal. Excretion is the same and the administration is same. Then this is called steady state. Steady state of the that drug. So this is about the half life of the drug, and this is about the steady state of the drug. So which is a 4 to 5 half life of the half life is required to reach a drug at steady state level. So this is very important, and you have to go through that. So this is all about the today class.